Well, it's nice to be here again. It's good to be among friends, and every time I come, I have new friends. It turns out that people that used to be residents join the faculty here, which is always the coolest. And I really feel at home here, so thank you for inviting me. This is a totally new talk. I've never given this talk before, so you'll tell me if it went okay.
So we won't see the cars going across the screen?
No, not this time.
Oh, okay.
It's a new talk. All of our pediatric headache specialists got together and put this together, and we all approved it and changed the slides around. So this talk is almost a national talk given by the peds experts around the country in headache. So I might as well just get started. Let's see, advancing is this way? Yeah. So
Start the slideshow.
oh,
Go down to the big box.
help me here somebody.
Put right down here.
This one?
That button right there.
We good?
Perfect.
All right. So these are the objectives we're going to come up with today. We're going to identify migraine as important, because it is. We're going to figure out the difference between sick kids and not sick kids. We're going to discuss who needs imaging and who needs a specialist. And we're going to develop a plan for treating migraine acutely, reducing attacks so that people can go on and have a good life. Now, this I put in. You have to stay till the end of the talk because there's a news flash at the end. All right? Stay tuned because there is actually new news in pediatric migraine just a few weeks ago. But you got to stay to the end. If you go, it's all right. I'll tell you another time. I'll tell you when I see you.
You know where I work.
I know where you live. All right. So this is what we're going to do. What is migraine? Migraine epi, migraine diagnosis, how to talk about education and lifestyle, what are some of the acute treatments, and what are we going to do to prevent? All right, that's first. So I hate this definition, but this is a definition that's been adapted. And I'll tell you what my definition is. This is the official definition. It's an inherited neurologic disorder characterized by sensory, autonomic, vestibular, cognitive, and GI symptoms. That doesn't describe somebody with migraine, right? So here's how you describe a kid with migraine. It's a kid who wants to sit in the dark, doesn't want to hear music anymore, doesn't want to eat. The headache is so bad that they can't function that day, they can't read, they just want to hide. That's somebody with migraine. Now, the important thing to know is that it's intermittent. Migraine is intermittent. If the headache is all the time, it's not really migraine, it's going to be special. But plain old vanilla migraine, that when you see somebody has migraine, they have intermittent attacks, they want to withdraw from the world, they want to be in the dark where it's quiet. That's my definition. It helps you figure out what to ask people. Tell me what you're like when you have your headache. If they say, it's intermittent, but I want to be quiet in the dark, it's migraine. Doesn't matter if it's unilateral or bilateral, if it's in the front, on the sinuses, in the back. It's all how you behave. If you want to lay in the dark and you want to be hiding from the world and you can't function, that's migraine. This is the classic definition that doesn't tell you anything. All right. Here. No? Okay. So, the phases of a migraine attack. This is that. This is that. This is that. Now it makes sense. Okay. So you start with how do you say that? Premonitory symptoms. That means your migraine starts before your headache starts. So some people feel tired, that even though they got sleep. Some people are yawning even though they're not listening to my lecture. In retrospect, you say it was going to be a migraine. That's premonitory symptoms. Only some people get an aura. Most kids don't have aura. But if you have an aura, it marches across your visual fields and then it goes away, and then your headache starts. Now, the postdrome is interesting. Some people after their migraine get really hyper and can do a lot. Some people feel like they've had a hangover. I don't know what that feels like, but they tell me that it feels like a hangover afterwards. So it's not just the red headache. Did we have a pointer here on the screen? No? Ooh, All right, I'm looking at the screen now. All right, it's not that good. It's not just the headache. It's all this other stuff. So when you tell somebody, describe your headache, you say, start from before it starts. What's it like? Because if you know you're going to have one, if every time you get your headache you have typical signs, do stuff. Get treated. Do something to try to abort the whole thing. Okay. Pathophysiology. All right, everybody wait, go to sleep. I'll tell you when the pathophysiology is done. All right. That's the slide that they gave me. This is my slide. I think this one's better. So there's 3 stages in a migraine. The first stage is a trigger. It can be hunger, it can be fatigue, it can be a drop of estrogen before a menstrual cycle, it could be a bright light, it could be too much screen time. Whatever your trigger is, without a trigger you don't have a migraine. The next step is what's called threshold. Threshold is your genetics. What that means is anybody can get a migraine, but most people don't because they have good genes, they don't have migraine genes, and they have a good solid threshold. But if you have migraine genes in your family, and there's been 20 of them already, your threshold is terrible, and that stressor will translate into a migraine later. That's step 2. The third most important step for us is right here. I'm going to point right there, and that's being particularly vulnerable that day. Because I can drink the same glass of red wine on Monday and not have a migraine, and the same bottle can give me a migraine on Wednesday because I am particularly vulnerable that day. So 3 steps in a migraine: a trigger, bad genes, and being particularly vulnerable that day. If everything lines up, go further down, you release a chemical called CGRP, and that inflames your meninges and your headache starts. That's all you need to know. Why is that important? This is what we do in the office, and you guys can do this. Identify triggers, see if any of these are preventable. You can't do anything about your threshold, but you can tell people not to be vulnerable. Not to be vulnerable means eat breakfast, keep your sleep regular, hydrate, right? Exercise. So those things make you less vulnerable. If you keep your life boring, you're less susceptible to migraine if you're a migraine person, right? Okay. So that's where the physiology hits the road. Okay, good. You done with physiology? Still awake? We good? Okay, epidemiology. Look how many people have migraine. It affects 1 in 11 children, 1 in 5 women, 1 in 16 grown men. That's a lot, right? So this is something you really need to know about. Now, this is cool. These are things, these patients will become, these children or babies will have migraine when they become adults. But you can catch it early, and when you catch it early, you're a genius. Colic. There's been studies that babies with colic have a higher incidence of migraine. So the question is, their nervous system is triggered earlier than everyone else's. Maybe irritable babies are having migraine. I don't know. But colicky babies have more migraine. All right. This is an interesting one. All right. Benign paroxysmal torticollis. This is usually a 5-month-old baby, went to sleep fine, wakes up stuck. What's that? So when you get that in your office, you're going to think, is it a tumor? Did somebody beat the baby up? What is that? So you do an MRI and you do a tox screen and everything's negative. It goes away and then it comes back, then it goes away. Those babies with benign paroxysmal torticollis will be migraine adults. Here's the next stage. This is usually a 2-year-old that's learned how to walk. They're fine. All of a sudden, their eyes get big. They grab their caretaker's leg and hold on for dear life because all of a sudden they have vertigo. Now, when that kid comes to you, the first thing you're thinking about is what? Toxic ingestion, right? The 2-year-olds try to kill themselves and parents try not to let them. That's their role. So You do a tox screen and it's negative. You may do an MRI because you're still worried about a posterior fossa. It comes out negative. Then it happens again and maybe again. And then somebody says, oh, it's benign paroxysmal vertigo. Set up an appointment with Dr. Gladstein. You're going to be in the headache clinic in a few years. All right, this one you will see, and you've seen this a lot. Cyclic vomiting syndrome usually starts at age 4. So we have the infant. Here's the tiny infant, the toddler, the preschooler. The CVS, these kids go to sleep fine. They wake up and they vomit 15 times an hour for 2 hours or so. They end up coming to the ER. They get rehydrated. They get sent home with a diagnosis of viral syndrome, and that's it. Then they come back 2 months later, the same thing. 3 months later, the same thing. Finally, somebody says, oh, you have cyclic vomiting syndrome. Make an appointment with Dr. Gladstein. You'll be having migraines in a few years. Okay, now, the average time from first event of cyclic vomiting until diagnosis is made, 2 years. So people suffer with this diagnosis for 2 years before somebody figures it out. You can figure it out sooner. Now, nothing else wakes you up from sleep and you vomit 15 times an hour, and then it comes back, and then it comes back. Now, some people say they should get scoped just to be sure, maybe get a metabolic workup. Some people do that. But invariably, it's going to come out negative, and that's your diagnosis. They are migraine precursors. And the last one, this can happen mostly in teenagers. And the problem with this one is there's a lot of things that it can be. These are kids that have everything that says migraine. So it's episodic. They want to lay in the dark. They have light and sound sensitivity. No headache, bellyache. That's abdominal migraine. That's not bellyache every day. That's something else. All right? The teenagers, the one that mimics this a lot is too much weed smoking. All right? These kids also will end up as adults with migraine. So if you see this, go ahead.
How many of the infants who have that go on to have migraine?
All of them.
All of them?
Most of them. I don't say all, most. Maybe not the colic ones, but the other ones, we call them migraine equivalents or migraine precursors. So if you see somebody and you figure this out, you ask them, who's got migraine in your family? And everyone will look at you cuckoo and they say, oh, okay. Cool?
Doesn't that kind of also mean that probable benign paroxysmal torticollis is caused by
Yeah.
maybe
Same thing.
the same?
Maybe it's the same physiology showing up different. Because kids, when they first start getting migraine, if they're little, don't have all the classic symptoms. So, yep. Okay. Now we're moving up to the epidemiology more. Prevalence over time. So the good news is if you get to be my age here, your migraines melt away a little more, both for women and men. But we're not talking about that today. We're focusing down here. Okay, I just told you how old I am. I old. Okay. Anyway, so the point for you guys is before puberty, boys and girls have the same incidence and prevalence. Once puberty happens, guys still have their migraines, but more and more and more girls do. So if you start your headaches after puberty, it's mostly going to be a female problem. If you run an adult headache clinic where most of your patients are between 20 and 50, it's going to be an overwhelming female problem. You see that? Okay. No, they took my thunder. There it is. The mean age of onset for migraine is about 8 years for boys, 9 years for girls. Okay. Now, this just proves what I said before, how big of a problem this is in our pediatric world. Migraine is just almost as much as ADHD. It's more than asthma, more than hay fever, and more than ear infections. And that's for people that diagnose migraine. A lot of people have migraine, they don't think they have migraine, or they haven't been to the doctor yet. So I posit that migraine is probably more common than ADHD. They exist together for a lot of kids. Okay. This is really even more important. This is school-related disability. And you'll see that. Who's that? Sue? Anybody talk? Who was that? Oh, just somebody said something. All right, at least you're listening. All right. All right. Anyway, so this just shows you that poor attendance, much common if you have more migraine. School-reported problems, much more common. Repeating a grade. Look at that. So this definitely is a serious problem for teachers and for doctors and for kids. Okay. Diagnosis. This is a busy slide. This is the one that Linda was talking about with everything connected and all the different patterns. I'm just going to show you. This is migraine. It comes and goes. It's severe. Don't worry about it. This is the one that I see in headache clinic. This is chronic daily headache. It just is always there. It gets a little better. It gets a little worse. This is brain tumor. It just gets worse and worse and worse over time. This one is called new daily persistent headache. You never had a headache, and now your headache is there all the time. That's something really bad. I hope you don't see it. If you see those, just send them. Okay? So the pattern tells you everything. Okay? So this one is reassuring, acute and recurrent. This one is reassuring in that it's not going to be a brain tumor, but it's the hardest to treat, and that's the kids with headache every day. Chronic, non-progressive. Got it? So pattern recognition is the first thing I do. First I joke around. I get people to think they're having a good time, and then I zero in. And when I zero in, first I say, tell me how often you have your headaches. I establish the diagnosis very fast, then we can do the rest of it. So this is the worry one. This is the brain tumor one, or the pseudotumor one here. This one could be worrisome, that it just starts. Or this is it. This is the thunderclap one, acute. Daily from start is this one, new daily persistent headache. And if your pattern changes acutely, that's a problem. Because let's say you had a brain tumor now, but you had migraine before, you're going to start with this pattern, and you're going to evolve into this bad pattern. Okay? Okay. Those are the types of primary headache. It's mostly going to be migraine. Tension type headache doesn't really exist. People think they have tension type headache. It's migraine. These are the weird things. Cluster headache in children is almost reportable. Don't worry about it. These are the bad ones. Trauma, brain tumor, infection, all that stuff. Okay. So here's what we do. We do your history. You screen for the red flags, and then you figure out if you want to do more. The red flags spell Snoopy. So systemic symptoms would be fever, weight loss, stuff like that. For girls, it would be losing your period and not pregnant. That's a systemic symptom that would make you worried, right? Of course, if you have cancer, if you're pregnant, immune deficiency, those would be secondary risk factors that would make you worry. Of course, neurologic signs. Onset is abrupt. If it's occipital, we have a debate. I don't care where your headache is located. Some people worry more if it's occipital. If the pattern changes we talked about, if it gets worse, if you lean forward, or if you change your position, or you have, when you orgasm, you have a headache, that's worrisome in kids. And if you're under 6, you need to be a little more worried. Okay? Is that all clear? So it spells out Snoopy. So, the red flags. If someone, when you have a migraine, it takes a good 60 minutes to go from the beginning till it's at full peak. If you go from 0 to 100 in a minute, I'm worried about a bleed. Worst headache ever is hard, because everybody thinks their migraine's the worst migraine they ever had. So I don't know about that. Now, if you start vomiting when you wake up every morning, I'm worried. Same thing if I have a headache every morning, I'm worried. If I have migraines, and some of them are early morning, I don't care, that's okay. If you have an abnormal exam, that would be worried. Or if you have some underlying immunocompromised state, then I'm worried. All right? Yellow flags means I'm a little worried, maybe. So a little kid, you worry more. If you start out with a new headache, you never had headache before, and you haven't had a chance to watch it. So if somebody comes in the 3rd week of a headache, and they've never had headaches before, it's a yellow flag. If it takes time to get in to see me and they've had it for 6 months, I'm a little less worried. Okay. If it's always on one side, that's a little worrisome. Most pediatric headache is bilateral. All right. And again, if it's worse when you increase your, if you have increased intracranial pressure and you just increase it a little bit, then that's worrisome. So if you Valsalva or you move your head down and the headache gets worse, that means you have pressure to begin with. So those are yellow flags. All right. So these are the official diagnostic criteria. All right. In adults, that's the ICHD, that's adults. Ped specifics on the right. So kids have shorter duration headache. It can be unilateral or bilateral. Kids don't tell you if it's pulsating. Severe, moderate, it's all behavioral, right? It's inferred by behavior. Little kids go lay down. They're not saying it's pulsatile, it's moderate or severe. They're just laying in a dark, quiet room, right? They should have light and sound sensitivity, and of course there's no other reason for it. So this goes more with the definition we spoke about a half an hour ago. So kids want to lay in the dark. It can be short-acting, it can be long-acting. Location doesn't matter, and it's inferred by behavior. All right. Some people say migraine aura in kids is 15%. Some say it's up to 30%. I think it's even less than that. So aura, you don't need aura. If somebody has aura, they're lucky because you tell them to treat their headache during their aura. Don't wait until the headache's full-blown. Okay? Aura is usually visual. It usually marches across the visual field with wavy lines. I keep turning my head. Can you guys online see me sometimes? Okay, no answer.
Yes, we can see you online.
Okay, good. Thank you for answering. All right. Aura can be 5 minutes. It usually takes about an hour. Okay. It can even occur without a headache. That's what happens to old people. Old people with headaches all their life end up with migraine aura without headache, which can be scary if you don't know to expect that, because then you're thinking you're having a stroke. If you're 60 and you have visual field changes but no headache, you're worried that you're having a TIA, right? But if you have a history of migraine, you can relax a little more. Most auras are visual. Don't worry about the others. Generalized blurry vision is common, but it's not an aura. Okay, this is the tough one. Who gets an MRI and who doesn't? First of all, nobody should get a CAT scan. A CAT scan is 100 chest x-rays of radiation. If you're going to image somebody, you do an MRI, not a CAT scan. The only reason to do a CAT scan is if you think somebody's bleeding and you're in the emergency room and you don't want them to code in radiology. You want them back in your ER bay as soon as possible. Then you do a CAT scan. Otherwise, if you're going to image somebody, it's an MRI. So who says yes? Well, if you're worried about a brain tumor, it happens. Some people really do have brain tumors. And 1 in 10 people with a brain tumor have headache as the only symptom. That's the scary one. That's for the yes people. It provides a peace of mind, right? So I call that a therapeutic MRI, not a diagnostic MRI. Okay? Okay. Now, why no? CT scan is radiation. No. MRI finds a lot of silly stuff. MRI finds a lot of incidental findings that need to be explained. So I don't know about that. Only 2% of the time it is anything meaningful. So what I do is I use logic. I say, if it smells like migraine, I've had period of observation, the exam is normal, I wait it out. And I tell people what to look for. But if somebody tells me I can't sleep without an MRI, I'll do it. That's a therapeutic MRI. But remember, if you do one that's not necessary and it shows all kinds of crazy things, you're going to have to explain that. So I said, don't do tests you don't need. I'm afraid to say this one. It's like picking your nose in public. If you find something, you have to do something with it. So don't do tests you don't need. All right. So here are the official statements. American Headache Society says there is no necessity to do neuroimaging patients with headaches consistent with migraine, normal neurologic exam, no atypical features or red flags. Okay. And the American College of Radiology says only if you have a specific reason, don't do it. Don't do CT at all if you have MRI. So is that clear? So if you're a worried person and a parent is worried, go ahead. But if it's migraine, you've had a period of observation, and your exam is perfect, no need. Good? Good? You guys still awake? No. Riley, she was up all night. So. All right. So here we get to the meat of it. Education and lifestyle. You guys can do this. It smells smart, not asthma smart. There's no extra A. It's -1A for smart therapy. But it's the same idea. This is about the physiology of that part where you are particularly vulnerable. This is where you teach people not to be vulnerable. You can control how often you get your migraines just by keeping the following things. Keep your sleep regular. Keep your sleep regular. Phones charge in the kitchen after 11 p.m. Try that one. They'll like you until you say that. That's when you lose the kid and the parent starts laughing. But that's what you do. What happens after 11 o'clock? Yo, what's up? Yo, what's up with you? That's what they do till 2 in the morning. And nobody wants to put the phone in the kitchen, charge it in the kitchen. All right. Don't miss breakfast. That means the kids have to wake up 2 minutes early and eat something. Exercise. 20 minutes, 30 minutes a day, minimum 3 times a week. You ask people, how are you going to do that? And then you problem solve together. How are you going to fit 30 minutes of exercise 3 days a week? Okay. Then learn to relax, not with a screen, whatever that means. And try to identify the triggers. And if you do, try to avoid them if possible. If it's too much screen time, limit screen time. If school has a screen, get blue glasses. Try to identify what your triggers are, and if they're preventable, prevent them. If a trigger is I'm being bullied at school, then the parents need to go to school and get that stopped. So identify the triggers. That's very important. So that spells SMART. So that even if you have your trigger, you could eliminate it if possible. Those are the things you can do to try to have kids control their own frequency of migraines. This stuff works great. It's hard to get it done. I teach kids box breathing. Do you know what box breathing is? Should I show you? Yeah. Okay, you could do this in clinic. It's cool. It means breathing in through your nose for 4 seconds, holding it for 4 seconds, breathing out through your mouth for 4 seconds, resting for 4 seconds. You have to be centered over your feet. You have to put your hand on your belly. So when you breathe in, your belly blows up. So it's like that. So I'll do it once. You can make fun of me. You can throw spitballs while my eyes are closed. All right, here it goes. That's a breath. You do 2 breaths in the morning before you leave the house. You do 2 breaths when you come home from school. This way you're good at it. And when your migraine starts, you do 2 breaths. It's magic. It's called yoga breathing. But people think yoga is hooey, so we just call it box breathing. Okay. Everyone can do a box. It's called box because it's 4, 4, 4, 4. All right? You can do that. You can teach your patients that. Because it's hard to find people to do this stuff. All right. These are some resources. It's in your packet. Okay. So we call this stratified care. If somebody has a migraine and it's not a big deal, and they have it 3 times a year, you don't need fancy medicine. Just give them an NSAID. Tell them to go relax for a little while. If you're sick enough to be coming to the doctor for this, that's probably not enough. Certainly if you see me, that's not going to be enough, because by definition, you've already alarmed your primary care doctor. So I would say you need a triptan, plus or minus an NSAID. How does a triptan work? Remember that physiology a half an hour ago, now 40 minutes ago? So when you have your trigger and you release your CGRP, you open up that gate. You can close that gate and stop releasing CGRP with a triptan. So the earlier you get it, the less bad chemical CGRP is released. Okay? Now, if somebody's really bad off and they're vomiting like crazy, you want to do a triptan, you might want to add an NSAID, and you might want to add an anti-nausea medicine too. Okay? All right, those are them, the doses. Don't worry about it. The tips really are use the highest dose of triptan you can find for your kid to stop it. This is the one time in medicine where you don't want to start little and go slow. You want to knock it out. You want to crush it. You want to reset the brain as fast as you can. So the first tip is use the highest amount of medicine you can get away with when you're prescribing. Rule of 2. All right. You can take a second dose after 2 hours if the first does. Don't do more than 2 in 24 hours. Aim for 2 days per week or less. That's the rule of 2s. There's no such thing as serotonin toxicity, so you can combine an SSRI with a triptan. The pharmacists used to yell at me all the time. It was an automatic red flag. They stopped that after the American Headache Society said nonsense. So go ahead. If someone's depressed, they can still get a triptan. All right. This is where Ashanti was worried about 45 minutes ago, if he's still listening. There are triptan side effects. Your jaw gets tight, your throat gets tight, your chest might hurt. It's not a heart attack. People who have that don't like it. I call it tryptophobia, fear of triptans. They're safe drugs. They've been around since 1996, almost 30 years. They're safe, especially in children. All right, you just tell people about it. So if it happens, don't worry. It goes away. It's not an allergy. Not to worry. These are the contradictions. Woo! Still listening.
I'll make sure that the prior authorizations come over to your office when I get that call.
You won't anymore.
Forward that to Jack Gladstein.
You got it. Okay. They've lifted them, by the way, because we yelled at them so much. Anyway, there are the list of cautions and contradictions: cardiac disease, cerebrovascular disease, rare migraine subtypes, uncontrolled hyper. Kids don't have this. So triptan away. Don't be afraid. Here they are. Here's the ages. Here's the doses. Just go. Don't worry. The ones you should know about that are different are Frova and naratriptan. Those are long half-life ones. Those are used if somebody gets better in your emergency room and you don't want them coming back the next day. You add that and some steroid for 5 days and they don't bounce back. That can also be used for kids who only get their headaches around their menstrual period. You can use that for 5 days as mini prevention. But otherwise, the longer acting ones don't have much role. There are 2 melting ones. That's the rizatriptan and the zolmitriptan. Because they're melting, they can be used for the little kids. The only one that has a shot is sumatriptan. There's 2 nasal sprays. You don't need to memorize this. Just the nasal spray, sumatriptan and zolmitriptan. So nasal sprays are for kids who are vomiting. Early morning headache where they wake up, they're really late in treating their headache, go right to the nasal spray. The shot can be used for cyclic vomiting. The shot can be used if you're really sick. Most kids don't want the shot. They'll do the nasal spray. This is an asthma action plan for migraine. Whoa! You hate those asthma action plans. I know you do. It takes you 5 more minutes to get out of clinic. So here's 5 more minutes out of clinic here. Same idea. You tell people, look, if your headache's early and you catch it early, use your over-the-counters. If it's really bad, triptan. If you're a real migraine person and you're sick, just go right to your triptan. All right? But again, green apple is do all the things you're supposed to do. Eat breakfast, get regular sleep, I could give the same list for asthma, for inflammatory bowel disease. For any disease that's chronic with intermittent flares, it's the same list. Be healthy. So be healthy to prevent your migraines. What to do as it starts and what to do when nothing works, when to call in, when to show up at the ER. Good? Yep. The nice thing about giving this to the teachers is they have the plan. They won't use. The nurse just needs to know what medicine to give, and the nurse needs to be informed by the mom on the first day of school, my kid has migraines. When the migraine starts, it's an emergency. She should go to the front of the line and get her migraine medicine and stop with this. For the teachers and the nurses, it's early intervention as soon as the migraine starts. Medicine needs to be at school. When you write your triptan, you write 1 box for school, 1 box for home on your prescription, split into 2 boxes. Sometimes if it's a family where kids live with mom and dad separately, you do 3, split it in 3, 1 for mom's house, 1 for dad's house, 1 for school. That's how you manage this. The medicine should always be available. For college kids, they should carry their medicine on them wherever they go. Okay? All right. Good. So camp is a problem. I get very busy in May and June doing all the camp forms, and the kids need a different pharmacy for camp. Oh my God. It's a mess. Okay. Here's your pearls. Oh my God. You ready for this? What time is it? Am I late already?
No, it's fine.
We're good?
Yeah,
You sure?
8 after 9.
Okay.
We've got 22 more minutes.
Awesome. All right. So here's the pearls. If you're nausea and vomiting, what do you need to do? Either add a nausea medicine or don't use the mouth. Use a nasal spray or a shot. If the NSAID doesn't work, forget it. Just go to a triptan. What happens if the triptan doesn't work? First thing you do is say, how long did you wait? Did you wait too long? Because as a migraine progresses, the triptans don't work anymore. So answer that question with a question, as we always do. You don't just take what people say. You ask, you dig a little bit. How long did you wait? Oh, I didn't have my medicine at school, so I waited till I got home. All right, next time take it right away. But if they did everything right and the triptan doesn't work, either change it to another triptan or change it from a pill to a nasal spray or a shot. Make sense? Okay. What about if the headache, every time the headache gets better and it bounces right back, then you might want to use the longer triptan. The names again are naratriptan, frovatriptan. All right. What if they're doing this more than 3 times a week? That means we got to do more. It means they need to see me. They might need to go on prevention medicine or work on their healthy habits more, explore if they're depressed, if they're having the comorbidities. The comorbidities are anxiety, depression, insomnia, and dizziness.
So, in your experience, it doesn't help?
No, it's not as good. NSAID's better, triptan's better. If they're coming to see you, I would say, for most kids with migraine, give them a triptan, please. It works. It's made for migraine. Okay. Migraine prevention.
Dr. Gladstein,
Yes.
to follow up on that, we have a lot of families who at home, they'll treat with Excedrin, migraine,
Nah.
of that nature.
Nah.
So when, they're coming in saying that.
Yeah, here's what you say. Excedrin migraine has a lot of caffeine. Caffeine is a vasoactive substance that can cause migraine. The more Excedrin migraine you use, the more likely you're going to get more headaches. So it's a bad drug. Don't use it. We have much better things.
And utility of caffeine, people will say.
No, don't use caffeine. Caffeine, it helps us get through our day. But why should we start our kids on caffeine? It's a drug. We got better drugs. We got drugs made for migraine. So why use something made for something else? Okay. So who needs to get more advanced therapy? Well, when you're missing a lot of school, that's called absenteeism. Presenteeism means you go to school, but your head's on your desk because you're not learning anything, because your parents have to work. If they don't work, they don't get paid, so they send you to school sick. That's why we have so many sick kids in school, because people send their kids to school sick, right? Okay. All right. More than 1 or 2 days a week, even if they're not missing school, that's already worrisome. Kids are so sick when they get their headache that the parents can't stand it because they're so sick they can't watch their kid be sick for 12 hours. You may want to consider prevention medicine. Or the stuff you use just isn't working. Those are kids who might need prevention medicine. Okay. Some people say, I don't want medicine. Give me vitamins. Okay. These vitamins actually work. B2, magnesium, and coenzyme Q10 come together in preparations. There's one called Migraine that puts that all in one pill. You can get the migraine.com. I'm not a commercial. But you can get these 3 things together in that. Some people think melatonin may work. I'm not so sure. All melatonin does is help you sleep. And if one of your problem is you can't sleep, then that fixes that. Maybe you'll get less migraines. Okay? And the thing about melatonin is you start little and you work your way up. You can start with as little as 3 milligrams for a teenager or 1 milligram for a school-age kid, and just titrate up. Maximum is 15 milligrams. Okay, these are some of the drugs. They're all terrible. Everyone has side effects. No teenager wants to take medicine every day. Half of them don't take it regularly. You don't want to do this unless you really must. But there they are. There's conflicting evidence about what works and what doesn't work. Use them with your comorbidities. This is, you may want to do this, or you may want to send them up to you. But if somebody, let's say, has a sleep problem, try amitriptyline, it'll make them sleepy, right? If somebody is real heavy, you may want to use topiramate because it makes you lose weight. If somebody has ADHD, never use topiramate. If somebody has a learning disability, of course, don't use topiramate. It makes you not think as clearly, right? So if somebody has POTS and they're dizzy all the time, use propranolol because it's a treatment for POTS. So if you've reached that conclusion where you need a prevention medicine, try to find one that kills 2 birds with 1 stone. Again, as opposed to a triptan where you want to hit him hard, you want to Mike Tyson him, knock him out in 30 seconds. Everybody know who Mike Tyson is? The guy with the snake and the tiger, that guy. All right, he used to be a boxer. Whereas prevention medicines, you want to go slow, slowly increase it till you get your effect. But when you start those drugs, you have to tell people it may take 3 months for it to work. So not unrealistic expectation. The problem I have is if somebody starts somebody on the first one and it doesn't work in 3 weeks and goes to the second one, then goes to the third one and goes to the fourth one, they come see me and they say, I failed four medicines already. I have to start over. So don't do that. Okay, all right. This was a very famous, controversial study that involved all the headache specialists in the United States. Incredible studies sponsored by the NIH, millions of dollars. People were put into 3, we were in this one too. People were put into 3 groups: amitriptyline, topiramate, placebo were followed out. It was stopped halfway through because all got better. Amitriptyline, topiramate, placebo. So they said, placebo's just as good, no medicine. Don't use amitriptyline or topiramate. Wrong conclusion. What happened was everybody got that first visit with a good headache doctor who told them to change their habits of life. That's what got them better a little bit. So I still use the drugs, and I find them that they're helpful. Yes, maybe if I gave you placebo, it would work too, because placebo rate is 60%, but I'm not giving people placebo. So if somebody says, what about the CHAMP study? You say, I heard on Grand Rounds at Mercy that there's a confounding factor why people got better. Okay. All right, that's what I just said. All right. So here we go. You want to, if you get to 50% decrease, you win. So if somebody had 15 headaches a month and they're down to 7, it's a win. Now, I would say 0 is a win. But these ineffective drugs that we've been using for the last 50 years, that's considered a win. I consider a win no headaches. So we keep working on it. But set those realistic expectations if you're using these lousy drugs. I'm giving you a hint that there are better drugs. Okay. Mitigate the side effects by starting low and going slow, right? Now, you tell people what to expect, and if it's intolerable, fine. So let's say you're using amitriptyline. The main problem is sleepiness. So you make people increase their dose on Friday night. So they'll be a little more sleepy Saturday, Sunday, ready for school on Monday. Does that make sense? That's how you mitigate side effects.
How often do you increase the dose?
Every week. Up to a starting dose. So topiramate, I'm in the weeds now. Topiramate maximum's 400. We start 25. In a month, you're on 100. Stop there. Amitriptyline, you start 10. At 30, you stop and you reevaluate. The main thing when you see somebody with this problem is a 6-week follow-up is key. you're making your plan, and then your next visit is to fix it. So that gives you a chance to ramp up your medicine and then see them back. I give people the summer off medicine. So everybody's life is better in the summer. I can go to Israel every summer. No one knows I'm missing. That happens. So what happens is people get better in the summer. They have less stress. They eat better. They sleep more. They're just better. So I tend to take people off in April and May so that they can have a summer without medicine and see what happens in the fall. So that's a good way to reassure the patient and the family that this is not a forever thing. Then comes this time of year and everybody's got migraines. All right. Duh. That's the duh slide. If treatment with nutraceuticals and pharma fail, consider referral to a headache specialist. You can send anybody you want to me. Some people are more comfortable with it. I'd be happy if you do lifestyle changes and a triptan. And then if they're not better, come see me. That's good. Some people get braver and are willing to try one prevention medicine that they think is right, and if that doesn't work, send them. If somebody has headache every single day, don't waste time, just send them. Okay, what's the cool stuff? So, remember we said CGRP? CGRP is the key to migraine. That's the pro-inflammatory chemical. That is the target of the newest drugs that are amazing, stupendous, best thing that's ever happened. I've had my clinic for almost 40 years. This is the game changer, CGRP drugs. CGRP is the drug that inflames the meninges and starts your migraine. So we have shots that you give yourself once a month that are monoclonal antibodies against CGRP. That's amazing. So the CGRP is released. The monoclonal antibody is the Pac-Man. It goes like this. The CGRP never gets to the receptor to inflame the meninges. We also have CGRP receptor blockers. So even if the CGRP is released, it can't get to the lining of the meninges to inflame the brain because the receptor is blocked. These are game changers. These drugs, we have some of them that are for acute treatment, and some of them are for prevention, and some of them are for both. Now, we have Botox. Botox we don't use much. It's 31 needles. 31 needles. Has to be done every 3 months. It usually wears off by the end of the third month and you're stuck. So kids don't want 31 needles for the most part. So we don't do too much Botox. You can do nerve blocks if you know how to do them. Nobody's really sure how a nerve block stops your migraine because what you're doing is you're hitting motor nerves and somehow it gets sensory nerves to stop firing. But you can do that. But I want you to focus on CGRP because that's the future of headache treatment. If I come back in a few years, I hope I'm still doing this. If I come back, then all I'll be talking about is CGRP because they'll be approved for kids. Right now they're approved for adults over 18 with one exception, which, thanks. Now, this thing is really cool. These two things right here. This one's called Nerivio. This one is a vagus nerve stimulator. Now, this one, you wear, it's called Nerivio, it's approved for kids. You wear it on your arm for 30 minutes every other day. It stimulates the part of the brain that shuts down your pain mechanism. So you're turning on your anti-pain. The migraine diagnosis we've been talking about doesn't involve the big brain, it involves the little brain. But you can modulate your pain by turning on your brain modulators. That's a brain modulator, and it works. You have less headaches, and when you get your headache, you can do an extra treatment. It costs between $40 and $80 a month if insurance doesn't cover it. Most people are willing to do it. You can use it in addition or instead of a prevention medicine. That's Nerivio, Nerivio, amazing. This one is a vagus nerve stimulator. The vagus nerve is the nerve that calms you down. It turns on your calming stuff, right? So vagus nerve stimulator, you put it here, you dial it up on your cell phone until it tingles, and you do that every day or every other day or even during a headache. and it can quiet your headache stuff. There it is. Arenumab, Ajovy, has been approved for children 6 to 18. This is less than a month ago. The problem is, insurance companies still don't want to pay for it. We have to yell and scream to get it, but it'll be easier to get it. And as time goes on, this will be easier to get. The others are close behind. This is called Ajovy, and I'll be prescribing it a lot. I still fight a lot about it. I hope my fight will get less difficult now that it's been approved for children. So that's the best thing. Now, in the adult world, still you have to fail 2 prevention medicines before your insurance company will pay for a monoclonal antibody shot. That's crazy. So American Headache Society put out a position paper saying we should be able to get the best drugs first for our patients. Why do they have to do this craziness? Okay, so in summary, it's easy to rule out the secondary headache conditions, right? You get your pattern, autonomic symptoms, intermittent headache, normal physical exam, migraine. So, but if you get nervous and something's not right, do what you need to do. That's how you make an accurate diagnosis. Kids go to school, so give them a treatment plan for school. That means some of the kids need a snack at 10 a.m. That's part of their treatment plan, right? Some of them need to carry a water bottle on their desk. That's part of their treatment plan. The nurses need to know that when the kid comes to, and the teacher, I'm starting my migraine, they go right out and get their medicine. And the specific goals are about days of missing school. Tell me how many days you're missing. If you're missing more than a certain number of days, I need to see you again because we need to do more. Okay? Limit disability as much as you can. Teach people that breathing technique. It takes a minute. All right? And behavioral means park your phone in the kitchen. Right? Thank you.